Well, good morning, and welcome all of you to the 5th year of the CVC. And I'd like to give credit to Dr. Golzar, who does that wonderful introduction. It stimulates all of us, I'm sure. So you are in the Venous session. I want to make sure you're in the right plane, taking off here. And I'm glad to have you. We have a very good panel this morning. And we have live cases this morning from Phoenix, Arizona, this morning and this afternoon. So it'll be very, very innovative, and we're really glad that we can do that this year. We're going to start off with a few introductory slides and to tell you about a little bit of housekeeping detail for the meeting, and then get the session started. I want to welcome you all and tell you about the directors. These are the founders of the CVC, which started 5 years ago here in Chicago, and I'm the Venous Program Director, and with me are the other people listed here for different areas of program development. And the mission statement, of course, is to make comprehensive, practical, and progressive education in both venous and arterial disease. Those are the many topics that we're looking at this week. I mean, in the next 3 days, we're going to cover a lot of ground. And Dr. Golzar and all of the people mentioned here are our champions and our directors for putting this all together. But Dr. Rodriguez will be in Arizona doing some venous live cases, and Dr. Montero Baker in Tucson doing the arterial cases on the other side. And, excuse me, I missed that. Well, we want to welcome everyone, of course. We have it's such a big effort to put this together. And the committee of people from the CVC team here, led by Renee Golzar, are here. You'll be seeing Jesse and Gwen and all the other people who are listed here around, and they can be very helpful to you. We want to make sure that you come to the ultrasound guided pedal artery case on Saturday if you're a fellow, and that is something that would help your practice. And we would also like to thank all of our industry partners. Of course, we couldn't do that without their support. And it's a tough road every year, especially when all the companies are merging. So every year is a new challenge to get their support, and we're very grateful. Now I want to start with just a little slide that none of us can read because it's in hieroglyphics. And it was brought to my attention in a book written by a good friend in Europe, Dr. Michel Perrin, who is a historian as well as a vascular surgeon. And he wrote up this, he's doing some vascular surgery history, and he brought about the fact that in ancient Egypt, they knew not to touch venous swollen veins. They had this advisory to everyone: if you recognized veins bubbling up under the surface of the skin, just to leave them alone. And it says, "Thou shalt not touch something like this." And that's the translation from the hieroglyphics. And we know from the time of Hippocrates, where they wrapped the legs and saw varicose veins and actually did statues in ancient Greece, that they used compression and knew not to touch wet gangrene. So where have we come since then? That's ancient Egypt, more than 2,000 years ago. We know that compression has been used and referred to in writings and in statues, sculptures, for over 2,000 years. We know that phlebectomy actually was introduced over 1,000 years ago. There were tools that were made, and people were credited for being able to do kinds of removing veins. Interestingly enough, when you look through the history of vascular surgery, the initial effort at sclerotherapy was almost 500 years ago in Europe. And then heparin, of course, has only been around 100 years. It's 1916 that was actually figured out, but not until 1935, that it was clinically trialed. Warfarin's only been around since 1954. Thrombolytic therapy started in Europe and in the States. It started in Europe first with streptokinase 45 to 50 years ago. And endovascular stents, actually, although they were first trialed in the 80s, actually came about here in the early 1990s. The first stents I put in were 1993 in the iliac system. And for those of you who don't know the derivative of the word stent, it comes from a dentist in Amsterdam who was named Dr. Stent. And he actually bridged some teeth with a device, and subsequently that became known as a stent. And then the vascular community picked up on that word when we started making stents in the late 1980s and early 1990s. So stents have been around only for a little over 20 years, and these ablation catheters and foam actually started coming on the scene in the early 2000s after some clinical trials. I heard about foam first in 2000 in Lyon at the European Venous Forum's inaugural meeting. So you see, we're actually in an infancy of an entire pioneer area, frontier, and we stand on the shoulders of a lot of people who have gone before us. So this meeting is actually a wonderful way for people to get educated more about something that's, we seem like we may know a lot about it because we do it every day, but we're glad that you're here to learn. And the panel and all of us are open to your questions during the meeting and when we're not giving the talks. So with that, I'd like to introduce the first speaker today, and that will be my good colleague, Dr. Tom Rook, who is from the Mayo Clinic in Rochester, and it's a great pleasure to have him start our meeting. You'll enjoy his talk immensely. Tom?
Well, thank you very much, Patty. I'm standing on the box. Hang on. There we go. That's a little better for me. One of the joys of being at this meeting is that I get an assigned topic and I get to follow it verbatim, because that sometimes makes it a little more challenging. There's the topic I've been assigned for today, and I'm going to follow it verbatim. The only disclosure of any merit that I should point out is that I went to college at the University of Michigan. This will become germane in just a moment. All right, well, Steve Dean is running around the back there somewhere. He's speaking at 2 o'clock today. He's a close friend of mine from the Ohio State University, and this is a common clinical scenario that the two of us encounter. The Ohio State University mascot will walk into our office and take his pants off. Common scenario. His complaint is usually something along the line of, my legs are painful and swollen. And he tells me, I think I have deep venous disease. Gene, what do you say in response to that? That's crazy. What are you, some kind of a nut? See what I did there? Yeah, okay, all right. Anyway, is that a fair assessment? Could he have deep venous disease? Well, maybe. I mean, what are the clinical signs and symptoms when someone comes in with a complaint like that ought to tip you off to something? Patty has charged me with this topic, and she would like me to discuss not only the clinical findings that would tip us off, but also the ultrasound findings. And she's given me 12 minutes to do that, except that now I'm down to 11. Well, these are the clinical and the ultrasound findings, and what I've put together for you to help you remember these today is a little mnemonic here. I want you to think of OSU nut for the clinical ones. These include the varieties shown here, looking at the first letters. Also for the ultrasound, there's a letter P for phasic waves. We're going to cover that in a minute. So I suppose the combined mnemonic looks something like OSU peanut. Anyway, let's go over some of these. The O comes from obvious disease. And obvious disease is obvious. This should tip you off to deep venous disease. If your patient comes through the door with a leg that's swollen and painful and looks like this, duh, you should suspect that there's deep venous disease present. Similarly, on a history, if your patient comes in with a massively swollen leg and the first piece of history they give you is, I've had a DVT in the past, you should suspect deep venous disease as the cause. The second thing is our S here for skin findings. Here's a man who comes into the office with some unusual looking varicose veins, but before you just jump out and remove those, you should look at the rest of his skin, because what's this guy got? Anybody know what these skin findings tip us off to? This is Klippel-Trelawny-Weber syndrome. And Klippel-Trelawny-Weber is associated with deep venous disease. How about this fella here? Elephant man walks into your office. Neurofibromatosis. Turns out that neurofibromatosis is associated with deep venous disease. Here's a patient that I took care of. You can see the neurofibromas and this gigantic mass in the neck, which turns out to be an 11-centimeter jugular venous aneurysm. You ready for this? This is the second patient I've seen with neurofibromatosis and a jugular vein aneurysm. So this is, this is, again, another case where the skin findings will tip you off to the presence of a deep venous problem. What clinical skin problem does this man have? His skin is ultra stretchy and it's easily bruised. He's got Ehlers-Danlos syndrome, and I can hear Gene sitting there saying, yeah, well, Ehlers-Danlos is associated with arterial aneurysms. I knew that, but it turns out it's actually also equally associated with venous aneurysms. Here's a large popliteal venous aneurysm in someone. And then here's a skin condition that you'll probably never see. I've seen one or two cases. They have these rubbery blebs all over the body associated with some prominent superficial veins. This is the blue rubber bleb nevi syndrome. And even though you're looking mostly at skin, these patients also have associated deep venous problems. Again, another patient with a popliteal aneurysm in the popliteal vein. All right, well, the next letter we come to is U, and that stands for unilateral disease. Sometimes unilaterality is very obvious, like in this patient here, legs way bigger. Sometimes it's rather subtle, like in this patient, where the leg's a little bigger on one side and only a little smaller on the other. But one of the things you always want to think of when you see unilateral disease, especially if it's left-sided, is this entity here, this deep venous entity, where the left leg becomes swollen because of compression of the left iliac vein by the right iliac artery there. And what is this? May-Turner syndrome. So this will tip you off to something. Now, another thing that tips you off to May-Turner syndrome can be the presence of these little veins in the skin at the site of the obstruction. And that's my segue into the next little clue here, the N of OSU nut, which stands for neoveins. These I'm talking about in this case are collateral veins. Anytime you see obvious big collateral veins running through the skin like this, you need to remember that there's almost certainly associated deep venous disease with this. Little tale about my nurse here. I have a nurse I used to work with, bent over on her way to work one morning to pick up a cup of coffee, felt something snap in her shoulder, and by the time she got to work, that's what her shoulder looked like. She said, there's something wrong. We said, yeah, all these veins popping up suggests there's a deep venous problem. We ran her upstairs, did a venogram on her, and sure enough, her deep vein was obstructed. This is a little curious because we were thinking this had to be a clot. We were about to lyse it when the tech moved her arm a little, and the vein opened right up. And what actually had happened here, if you look at her x-ray, and I enlarge this area, you can see one piece of her first rib there and the other piece there, and it's fractured. She had fractured and displaced her first rib, and it was compressing the vein. But the clue to the sudden appearance of these veins was that the deep vein system had been obstructed. And sure enough, we took her right to the operating room, took out that first rib, and by the time she came back, the obstruction was gone and the veins had disappeared. Another clue here, the U of nut, unusual symptoms. Always suspect deep venous problems if the symptoms are unusual. 28-year-old man with left leg swelling and claudication during exercise, that's an unusual thing to begin with right there. We studied his arteries, and they were fine, but his compartment pressures went up with exercise. And when we looked at his veins, what we found was that he had popliteal venous entrapment. And sure enough, for those of you who may not believe that this entity exists or is real, hello, Dr. Dean, the operation to remove or to release the popliteal compartment here gave him complete relief from his symptoms. T, that stands for troublesome trends. And the idea here is that as we trend from less severe disease to more severe disease, the chance that we're going to have deep venous involvement increases. In fact, just right off the bat, if you think of C4 to 6 disease versus C2 disease, your chances of having deep venous involvement with the higher C numbers are 2, 3, 4 times higher. So just look at it this way. We all know the SEEP class. We wouldn't be here if we didn't know this classification scheme. But just remember that if your patient comes in at one extreme end of it, say varicose veins only, your chance of having deep venous involvement is small relative to the chance of having it if they come in with inflammation or ulcers, in which case it's very high, more likely than not that they have deep venous involvement. And that brings me then to the last category, which is the radiology one, the ultrasound one. And again, obvious radiology is obvious here. If you're looking at a groin mass with exercise, a groin mass with ultrasound trying to evaluate a problem, and you happen to fancy across one of the veins in there, they better look like this. If you inadvertently encounter a vein that looks like that, that should be a clue that the patient has deep venous disease. Of course, we see other little tip-offs like this in other types of radiology all the time. We're constantly doing CT scans to look at chest problems and picking up inadvertently things like this, or doing a flat plate of the abdomen or a chest x-ray and noticing that the patient has a IVC filter in that they didn't know about. If you see these kind of findings, obviously that's a tip-off to deep venous disease. But the one finding I wanted to just remind us of, the one I think Patty would have wanted me to bring forward here, is this phenomenon. Often we're looking at deep veins and not really looking for clot. And as we come across the veins, we'll notice this type of a pattern, especially proximally, a phasic pattern, phasic with respiration, or phasic in the sense that it also has some pulsatility to it. When you come across, even inadvertently, a proximal venous signal that looks like this is one of those things that should make you go, because what you've done here is you've lost your phasicity. And even though the veins that you're visualizing may look perfect, this should be a clue that somewhere upstream you may have some kind of obstruction like this, and you're picking up the downstream non-phasic signals just as a little extra pickup. So that leaves me then with the P of the OSU peanut. So just to kind of summarize here, the mnemonic that I'm using is OSU nut, stands for obvious disease, skin findings, unilateral disease, neoveins, unusual symptoms, troublesome trends, and then we throw in that P here, the phasic waves. And when you think about the skin findings, you know, this kind of hemosiderin discoloration is technically known as tattooing. It tattoos the skin, and obviously that's a very bad tattoo. But I just want to leave you with the idea that when it comes to leg tattoos, there are some, Steve, that are even worse. Thank you very much.
Thank you. I'd like to invite to the podium now Dr. Daugherty. Stephen Daugherty is from Clarksville, Tennessee. He's a vascular surgeon, and he's going to talk to us now about venous ulcers related to the iliac venous compression.
Thank you, Patty. I appreciate the privilege to be here. When I was asked to do this, I thought, well, venous ulcers related to iliac venous compression, that's a small group of patients. I want you always, when you see a leg ulcer that you think is venous, to think about an iliac vein lesion. It's more commonly actually obstruction from a post-phlebitic change, but these are real lesions as well, and you need to think about them. I don't have any disclosures. Iliocaval obstruction may be thrombotic, often multiple levels, or it may be non-thrombotic. The obstruction in non-thrombotic is permissive. It allows an environment with venous hypertension, which makes you more prone to have problems downstream from that. But in looking at the literature, I found something that correlated really with what I'm seeing. That is, only about 4% of venous leg ulcers are due to non-thrombotic iliac vein lesions. Well, non-thrombotic obstruction usually is compression, usually arterial, can be other things. You can see some strictures that are post-operative or post-radiation. Look for other causes of venous hypertension when you see an iliac vein non-thrombotic lesion and an ulcer, because usually there are other things going on that are probably as much or more significant that you need to deal with as well. Commonly, you'll have lower extremity phlebosclerotic changes, superficial venous insufficiency, deep venous insufficiency, abdominal obesity, poor calf muscle pump function, chronic dependency. These people often are sitters. And their local issues, trauma, abrasions, peripheral neuropathy. Look for arterial issues, infection, malignancy. So look for all of these issues. Don't just blame the iliac lesion, though it may be an important lesion to treat as part of this. In the history, look for venous thromboembolism, trauma, arterial and venous lesions, smoking, collagen, vascular disease that would affect the microcirculation. In terms of symptoms, look for leg swelling. Most of them will have that. Some will have venous claudication. Many will not because they don't walk enough to develop it. And look for pain at rest or elevation, which may clue you off to an arterial issue. Some have pelvic and low back pain. Those are actually fairly common in some of these patients. This is an early venous ulcer. We're getting more of these early now than late. We use ultrasound to do our initial workup on these patients. We look at the lower extremity venous system. If there's any question about arterial flow, we'll look at the arterial system as well. But I think all of these patients with what we think are venous leg ulcers should be evaluated with abdominal and pelvic venous color duplex ultrasound studies. Some don't feel that their ultrasound is good enough to do that, and they go straight to CT or MR. I think that's a mistake. I think they should focus on getting better ultrasound because there's so much that ultrasound tells you that you won't see on CT or MR. And finally, venograms and intravascular ultrasound are the real definitive diagnostic tools that you use to evaluate these. This is an ultrasound, and we'll see if I'm able to show you this with a mouse. I don't think my mouse is going to work for me. We'll try a laser pointer. This is the compressed common iliac vein here, and this is inferior vena cava. This is the artery. So we have a 2.2 millimeter diameter vein right there. This is another ultrasound, and these are the iliac arteries crossing the common iliac vein. This is the vertebral body back here. So this vein is kind of arched up over the vertebral body like that, and then it's compressed. That's what you typically see. The common iliac vein here, you see this with a high velocity. This is a peak venous velocity of 52 centimeters per second across that lesion. That's very abnormal. And an internal iliac vein, this was a patient who had kind of biphasic flow in the internal iliac vein at rest, but after exercise, it was a retrograde flow, and that pretty well nailed the diagnosis of a hemodynamically significant lesion. Our ultrasound techs put together drawings for us, and this shows compression of the iliac vein here, retrograde flow in the internal iliac here. We had a diameter of 4.5 millimeters here with the minor diameter across the compression compared to about 13.5 millimeters down here. So that's a high-grade compression. Well, peak venous velocity is significant. I don't know of any parameters that are really well validated for peak venous velocity across the lesion, but I can tell you if you get a peak venous velocity above 40 that it's usually very highly significant. Labropoulos looked at peak venous velocity ratios measured at the highest velocity across the venous stenosis compared to reference velocity below that level. And they found that a ratio of above 2.5 suggests hemodynamic significance. That's generally true. We occasionally see one that's considerably less than that where the lesion is real, but in general, this 2.5 seems to play out fairly well to help sort these out. In China, a recently reported study of normal women who underwent CT scans showed that there was a greater than 50% diameter compression in 52% of women and greater than 70% in 24%. So the actual presence of a compression does not mean that it's significant. The amount of flow and the degree of obstruction due to the geometry of the lesion is more significant than these absolute numbers. This shows an MR of one of these lesions. This is inferior vena cava, common iliac vein compressed by the right and the left iliac arteries, just so you have an idea what it looks like in that. And these are multiple varices in the pelvis that you'll often see with these patients. This is a venogram showing decreased contrast density across here where the lesion is, cross pelvic collaterals left to right here. There's often ascending lumbar vein. This one's very faint, but there's commonly an outflow pathway here that goes around the obstruction that you'll find. And finally, intravascular ultrasound is utilized to help sort these out a little bit further. Now the question is, can we get this thing to play? We had it working downstairs, but I don't have controls that are making anything work up here right now. The people in the back make this thing work. Can you play it? We've got a before and after intravascular ultrasound. That's a stent inside this. This is the second one. That's a stented area where the lesion was. And we're just pulling back through the stent, so it's wide open, the stent. Now let's go back to that slide before this one. Now let's play that video so we can show them the before the stent. All right, this pulling back from the inferior vena cava. You see it getting very narrow. And this is the iliac artery. This is vertebral body here, and this is iliac artery right here, and the vein's just smashed out flat in there, just held open by the intravascular ultrasound catheter. So those are the kind of things that you see. And you won't find these if you don't pay attention. You need to look for them. The vascular world is learning very rapidly that we have been missing a lot of iliac vein lesions that have been underlying significant factors in venous ulcers in the past. The leg issues with post-phlebitic changes are important, but these are very important things that you don't want to miss. And I would suggest you ought to treat the iliac vein lesion first if you are convinced that it is hemodynamically significant. This is what this patient looked like after a stent was placed. Stent is here. The cross-pelvic collaterals are gone. Ascending lumbar vein you don't see. There's good contrast density through here. Thank you very much.
Good. Thank you very much, Dr. Daugherty. Dr. Gene Zeeler from Seattle, Washington is a vascular surgeon at the University of Washington. And he was here last year with us. Thank you for coming again. He's going to speak to us about ultrasound evaluation of venous pathology.
Yeah, thank you very much, Patty, and I appreciate the opportunity to be here. So my topic was ultrasound evaluation of venous pathology, and this is a pretty big topic. I have no disclosures relevant to this pretty big topic. So I thought about what I might say, and I started off with this list of clinical applications of venous imaging, obviously looking for acute deep vein thrombosis and chronic venous insufficiency and some of the other more specialized applications. And what I thought I would do is just make a list of some of the points that I often talk about when we discuss the evaluation of ultrasound evaluation of veins. And of course, we have other ways of looking at veins. Duplex imaging with ultrasound is just one. The physiologic tests are another, but we'll focus on ultrasound today. So in the time that I have, I'll make a few points about technique, talk about diagnostic criteria, make a few points about isolated calf DVT, talk about acute versus chronic DVT, and then follow-up of acute DVT and interventions and chronic venous insufficiency. So as you see, I can spend about 1 minute on each of these different topics. Patient position for a technical comment is important when we do our exams. We tend to do our acute DVT exams with the patient's feet down and their head up so that the veins are full. And this is not something that's trivial. If you actually examine your patient with their feet up in the air, with their head down, the venous flow patterns are very different, and they tend to be dominated more by cardiac events. If you put their feet down, then they're dominated more by respiratory events like the respiratory phasicity that Dr. Rook mentioned. However, for evaluating chronic venous insufficiency, it's extremely important to evaluate the patient in the standing position, and I'll talk a little bit more about that later. So the diagnostic criteria for DVT or venous obstruction fall into two categories: B-mode image and color flow criteria, and Doppler criteria. So B-mode imaging alone is useful, but it's not a complete way of evaluating the veins for obstruction. Some thrombi are very hypoechoic, and color flow is very useful for demonstrating where the flow is and for demonstrating flow around hypoechoic thrombi. And this increases the sensitivity of B-mode imaging quite a bit. Compression ultrasound is probably the primary modality that we used for diagnosing obstruction of veins. And all the sonographers in the room are very aware of this, but sometimes the physicians are not, and that is that it's important to do your compressions in a transverse view so you can see the whole vein and compress and not roll off the vein and get kind of a pseudo-compression. And I, too, am waiting for these videos to run, and we'll give them another, there we go. So these just show a normal and an abnormal compression. The abnormal one is on the right. You can see the common femoral vein not compressing, and the video on the left doesn't want to work for some reason. There you go. And the normal compression should go down to almost no width whatsoever. Partial compressions are abnormal as well. Now, you've already seen an earlier version of this slide. My colleague Tom Rook already talked about the importance of phasicity, or the P in peanut, I guess. Go Michigan. And this is not so much an anatomic test as a physiologic test. If you see the phasicity in a common femoral vein, as shown on the left side, that's a good sign that the proximal veins are open. Now, it doesn't rule out non-occlusive thrombus, but it does rule out occlusive thrombus. And the continuous signal on the right side there is abnormal and is an indirect sign of venous obstruction. Now, it doesn't tell you if that's intrinsic thrombosis or extrinsic compression, because this is an indirect test or an indirect sign. But the respiratory variations are just not transmitted through the venous collaterals very well, and that's why we get these continuous signals distal to obstructions. So this would be an indication to use your duplex imager, go proximal, and find out why that was taking place. What about calf vein thrombosis? We divide the calf veins up into the so-called axial calf veins, the tibial and peroneal veins, and the muscular calf veins, gastroc and soleus, is shown here. And we've gotten very good at detecting these, particularly with modern duplex imaging with B-mode and color. And I think it's very important to study these. The Intersocietal Accreditation Commission's vascular standards for venous testing now do include scanning of the calf veins. And the ACCP guidelines for treatment recommend treatment of calf DVT in selected patients. And the recommendations have varied over the years. But in general, axial calf DVT should be treated when there are severe symptoms and when there are ongoing risk factors. And if for some reason they're not treated, or if there are no symptoms and no ongoing risk factors, then serial duplex at 5 to 7 day intervals for about 2 weeks is what's recommended. So it is important to do this. The approach to axial and muscular calf DVT is usually the same. If we just see isolated solear or gastroc DVT, we generally regard it as the same as an axial calf DVT, but that is somewhat controversial, and there's some experts who feel that isolated muscular calf DVT is relatively benign. What about acute versus chronic deep vein thrombosis? We, in our own lab, do not make any attempt to try to report whether a thrombus is very acute or subacute. I don't think those terms have any standardized meaning, but there are features that point more toward an acute thrombus versus a chronic thrombus, and they're listed on this slide. The ones that I think are most helpful is that a acute thrombus it tends to be relatively hypoechoic or isoechoic, and that's where the color flow is very helpful to detect these and complete compressions. If it's soft and deformable, that's probably more acute. If the vein's dilated, I think that's a very good sign that it's more acute than chronic, or if there's a loosely attached section or a free-floating tail, that points to a more acute thrombus. So there are features in the extremes that point to either acute or chronic, but there's a lot of gray areas in the middle where you really can't tell. What about follow-up of an established DVT? How do we evaluate that, and how do we use that information? And there are actually a lot of studies out there that have addressed this, although I think it remains somewhat controversial. This is Prandoni's study that looked at a large number of patients who had been treated for an established proximal DVT with anticoagulants for a 3-month period, and after that they were randomly assigned to either a fixed-dose anticoagulation for up to 3 more months or ultrasound-guided anticoagulation. And this was no anticoagulation for recanalized veins, and then a period of anticoagulation for residual thrombus. And this was defined by non-compressibility. And then they followed these patients up. And it turned out that with fixed-dose anticoagulation, 17% of the patients developed recurrent DVT, but with ultrasound-guided anticoagulation, only 12% developed recurrent DVT. So that was about a 35% reduction in the incidence of recurrent DVT with continued treatment based on the ultrasound results. So they concluded that adjusting the duration of anticoagulation based on ultrasound findings reduced the rate of recurrence of VT in adults with proximal DVT. And there have been a variety of other studies that have addressed this, and some have shown positive results and some have not. So the jury is still somewhat out on that. We don't think that there's any indication for follow-up duplex during the period of treatment, that is, during that initial 3-month period. And even though we often get patients referred to see how they're doing on treatment, there's really, I don't think, a major role unless they develop new symptoms and they suspect that the treatment is simply failing to work. Follow-up after venous procedures is something that we can do very effectively with venous ultrasound. And I'll be talking this afternoon about follow-up of iliac vein stents. But one application that I was just going to mention in this particular category is follow-up after venous ablations, which I'm sure will be talked about by others. But this is a very focused, directed exam that is done usually 5 to 7 days after the ablation procedure. And we do this in our clinic as a point-of-care exam. We rarely do this as a formal vascular exam in the laboratory. Unless there are positive findings, in which case we would get a complete exam. But you can see in these examples the thrombus extending right up to the common femoral vein, and in the example on the right, extending into the common femoral vein. And this is the kind of thing that we would want to detect and follow and perhaps even treat in selected cases. And in the last couple of minutes, just want to talk a little bit about the evaluation of chronic venous insufficiency. In this case, we not only want to detect obstruction, which we've already talked about, but we also want to detect reflux. And in this context, the method used to elicit reflux is particularly important. We know that it takes a certain reverse flow velocity to physiologically close a valve, and this is about 30 centimeters per second. And we also know that this threshold velocity is achieved by Valsalva proximally, but it's not reliably achieved more distally by Valsalva or by manual limb compression. So the most effective way to do this is with cuff deflation, and to do this in the standing position, which is physiologic. And this helps us localize the site of the reflux in a standardized, reproducible way. In order to do this, we need a little bit of extra equipment. We need this automatic cuff deflator and these specially designed cuffs that have relatively large tubing. You can't use pressure cuffs for this because the larger tubing is necessary to get the air in and out very quickly, because the cuff has to be deflated in about 1/3 of a second in order to simulate muscular contraction and relaxation. And we image about 5 centimeters above the cuff. So this is kind of a fiddly exam, and if there are any sonographers in the audience who do this, they'll know what I'm talking about. But it's important to set the room up nicely so that everything is within easy reach, and there the foot pedal controls the cuff inflator deflator. And so this is the setup for the common femoral vein, or also the saphenofemoral junction. You can see the large thigh cuff there. Here's the popliteal vein with the calf cuff, and the great saphenous vein, same cuff, and tibial veins. And normally the valves should close within about half a second using this technique, and some labs use as much up to a second for the deep veins, and even less than half a second for the perforators, as you can see there. In our lab, we use half a second for everything. It just keeps it simpler and is very clinically helpful. And it's usually pretty obvious what's going on. The examples of normal valve closure are shown on the left. The large spike is the inflation of the cuff, which is essentially an augmentation, and then the arrows show the cuff deflation and the cuffs, rather the valves closing very quickly, and the abnormal reflux flow on the examples on the right side. So in summary, I've gone over some tips and techniques regarding evaluation of venous pathology by ultrasound. I talked about position, the reason we use the foot down for DVT, the value of color flow to identify non-occlusive thrombus, the value of compressions and the importance of the transverse view, extrinsic compression versus intrinsic thrombosis when you see continuous venous flow patterns, a little bit about calf veins. Don't obsess over acute versus chronic DVT. There's a possible role for duplex in the guiding treatment for proximal DVT, although it remains controversial. Follow-up after venous procedures can be done as a point-of-care ultrasound, and reflux has to be assessed in the standing position. Thank you very much.
Well, thank you, Tom. Thank you. I'd like to introduce the other doctors on the podium that I didn't introduce before because they're speaking a little bit later, but Dr. Sharifi from Phoenix, Arizona is here, interventional cardiologist, vascular surgeon, and Dr. Nieves from Bogota, Colombia, vascular surgeon as well. So also make sure if you have questions, we'll have a question and answer session right after my talk. I'm going to talk about intravascular ultrasound, which I've had the pleasure of doing in the lab for many years. And I think that's unusual for an interventional radiologist because the interventional radiologists are the last on the block to kind of use IVUS on a regular basis, and I think it's partly due to access to the equipment as much as then appreciating what you can see that you think you see or you don't know that you don't see. So you only see what you look for. That's an old thing that we're taught a long time ago. You only see what you look for. That's true in everything, isn't it? And you only look for what you know. I mean, if you're looking for a penny on the ground, you don't know what a penny looks like, you walk right by it, right? And you only know what you've learned, what you've been taught. Now, how do we learn? We learn with empirical knowledge or trial and error, as my father used to say, the school of hard knocks. If you want to go there, you can. But people try to help you stay away from that by teaching you what they've learned. And then, of course, you have to always analyze what you're being taught by other people to see if it's really right or really wrong. You can't just blindly believe everything you read or hear from others. So it requires thinking. And you can accept it or reject it. But then, of course, that requires an amount of knowledge on your part to analyze it appropriately, doesn't it? So learning is complex. So where this comes in is kind of interesting, serendipity. I think Dr. Rook has used a slide about serendipity before, and I think it's a fabulous concept, and it applies to us all because we have this linked together, these aha moments where innocuous facts come together in a pattern that makes sense. And in medicine, there is a sixth sense about things. And I was sitting here, I realized that I forgot one other slide that I would like to have put up, and I use visualization. I think all physicians who do endovascular work use visualization. I know the wire can go someplace. I can't see the hole. I know it's there if I do the pathology. I've been taught that. But I can't see the contrast going there until maybe a day or two of lytic therapy. But I know it's possible. I know that I visualize it, just like they teach golfers to visualize where they want the ball to go. I visualize that the vessel is there. It's not gone. It's just thrombosed, and it has these fenestrations in it. And how do I know that it has fenestrations? Two ways. One, when I was a fellow, I got to study with Dr. Jesse Edwards in Minneapolis, fabulous pathologist, who showed me a lot of arterial disease from the coronary. And in the middle of coronary thrombosis are fenestrations. A vessel that looks totally occluded by any other means has microchannels. So we started seeing that with IVUS, which I'll show you. So how do we image veins? Inside veins with IVUS, which we're talking about. Outside the vein with duplex, which we've just seen with Dr. Zeeler. Venography, CT, MRI. We don't do too much cut down on veins, direct visualization, but any vascular surgeon can tell you that when they've looked at veins that are thrombosed, and they've had a lot of pictures of those, they say, well, it must be almost impossible to get these veins open because they look so sclerotic and actually really ruined by the process of chronic thrombosis. So we're learning what we didn't know through some of these other imaging techniques. Here's a nice 3D image of the venous system because we inject contrast through the sheaths in the popliteal to get a pacification of both the veins and the arteries with CTA technique. Here again is that famous flat line non-phasic flow. And of course here is a venogram which indicates a partial May-Thurner, and we don't know how bad it is until we look with IVUS. And then when we look with IVUS, we can see that it's quite narrow, AP, anterior-posterior, and quite long or wide with a transverse diameter. So this helps us decide what size stent we're going to use. Now, what I've learned a lot about IVUS, which I want to share with you today, is the behavior of thrombus. Because everyone used to say to me, Patty, why are you using lytic therapy? Oh, this guy's got thrombus for 2 years or 2 months. It's chronic. It says in the book, anything over 10 days, it's not lysable. Now, I'm not exactly sure where all of that came from, and it has to do a lot with the amount of fibrin that can be lysed, et cetera. But we found by doing that things change. And in the beginning, before IVUS, we didn't know how it was changing, but I can show you now that when a clot looks like this, which is in formation in the vein, it's forming in the middle of the channel, and part of it is stuck to the wall. Now, how does it get from acute to the chronic condition like this where you can't see it? It's time. And I'll tell you that patients have a spectrum of firmness of their clot. It must be genetically determined because all clot is not the same. This is a electron microscope of blood corpuscles with strands of fibrin, platelets, macrophages are in there somewhere. This is what a clot looks like under electron microscopy. And we know that platelets are really sticky when they're activated. They have all these spicules. These are unactivated. So they play a role in thrombus. But in venous thrombus, we don't know exactly what the role is. No one's ever studied that very much, just on the arterial side. And under a dark field microscope, we can see that people with different types of blood have different amounts of fibrin and platelets. This is A positive 2 weeks after DVT. See how the blood corpuscles have taken a rouleau, or the stack of pennies look? And here, look at all the fibrin in this particular slide. This is also B positive, or non-O blood. And then when you look at an O blood, you see there's very much a paucity of fibrin. So the blood corpuscles are sort of sailing around freely. They're not all stacked up and clumped together. So does that have any implication in how thrombus organizes or forms? We need to study that more. We know, of course, that the number of patients that we see with post-thrombotic syndrome are mostly non-O blood. And most of the patients we see with DVT actually have to have A negative or A positive blood type. And Dr. Rook is going to speak a little bit more about that today. Now, when you look at IVUS, and you look multiple times, you start to see patterns over and over, no matter if they have acute clot, 2 months old, 4 months old, 2 years old. The body is doing a similar thing. And what we see here is what I call the ring sign. The thrombus is in the middle of the vessel, and there's this lucency. You could call it a ring or a tire, but what's happening is there's some lytic process going on at the wall level. So we suppose, and I know there have been studies done by Dr. Wakefield and others, that we're secreting our own enzymes at the edge through the vascular wall, through the membrane there. Now this is another sign of a ring sign. You can see there's more thrombus here. This is the probe, IVUS probe, and here's the ring sign. Many different patients over and over, even with a stent in place, you see the lysis of the thrombus within the stent shows you this ring sign prevails. There's another example. There's another example. Now, what about the fenestrations I mentioned? I wasn't surprised to see them because of what I knew from the arterial side. But you see these little microchannels? Well, that's the process of recanalization that's going on. You see, in the old literature, it says, well, don't worry, if you have a DVT, you'll recanalize. But if you're the person who recanalizes 10%, and Dr. Rook is the guy who recanalizes 90%, you're going to have two different outcomes, won't you? Recanalization isn't complete in all people because you get residual thrombus. This is a channel, this is a channel, and what is this? This is nothing more than the coalescence of microchannels after we've been using lytic therapy. So then you have some residual thrombus here. When you do a venogram, it looks pretty good, but when you do IVUS, you see how much is left over. Now, the other use of IVUS that's really hot right now is this measurement of the iliac stenosis and the baseline measurements of the vessels, so you can kind of decide what size sheath would be most appropriate. So this is a May-Thurner that's post-thrombotic. This is a May-Thurner that is actually opened up with lytic therapy. It looks non-thrombotic now, but it was thrombosed. And you can see it's complex. Here's this arterial impression here. And we use IVUS to decide where we place the stent and the size of the stent. Now, the other place I think IVUS is really useful is in monitoring stents, because if patients come back and they go to Dr. Zieler or any of us and say, my leg just doesn't feel as good as it did when you first treated it, I'll say, well, maybe there's something going on in the stents. Well, you do the ultrasound, and it shows flow, and it's blue, and it looks great, and there's phasic flow even. But if you measure the velocities, sometimes they've changed. They've decreased instead of increased, because usually intimal hyperplasia in veins isn't very focal. It's kind of uniform. And what happens is you can bring them back for a venogram, and you can see that there's restenosis all along the edge. And it doesn't look very much, does it? It's a little bit inside the stent here, but you know that much encroachment on the lumen is about 40% of the luminal diameter, or more sometimes, and it is enough to give them high pressure in that leg. So they start to become symptomatic again. So we do angioplasty, push it way back. Here's another side, intimal hyperplasia, pushed back. It doesn't completely go away. We need tools to take that stuff out. And we know that it's intimal hyperplasia with smooth muscle replication, etc. So in all, there are a lot of ways that IVUS can help you. If you're just getting started into doing venous disease, or if you've been doing it for a while and you're following your patients year after year, and someone comes back with is resymptomatic, then you must treat them. And IVUS is very important for analyzing that. So thank you very much for that. So now we have time for some questions answered for anybody on the panel. If you'd like to go to the microphone in the middle, we'd welcome anybody have a question. Anybody on the panel have a question of anyone? Do you? Okay, good. I always think these are the best part of the meeting, to have questions come from the floor. So.
This question is for Dr. Rook, and it involves a relationship with unusual calf pain, the U. And I was curious as to the relationship, if any, between venous compression causing the deep venous disease and compartment syndrome. Was there something component-wise that was cause and effect, or how did they relate to one another?
Okay. Great question. And this is, if I'm understanding the question, sort of what you're asking is, we've got this compartment syndrome, we've got this intermittent popliteal entrapment of veins. What part of these syndromes overlap? Are they the same? Are they different? And the answer to this is, I don't really know, but I'm extremely curious about it for right now. For years, we were all taught about exercise-induced or chronic exercise-induced compartment syndromes, but the mechanisms have always been spooky. Why does the compartment pressure go up in some people with exercise? And folks would postulate weird permeability things that, that some people would have that other people wouldn't have. To me, it always seemed very logical that if you had venous obstruction during exercise, or venous obstruction perhaps that wasn't significant at rest but became significant with exercise, that if the blood can't exit your calf and backs up into the calf, that the pressure will rise, and if it does so inside a fixed compartment that's not very distensible, your compartment pressures ought to rise. So I've been thinking for years that what we're calling exercise-induced compartment syndrome would likely be simply a manifestation of venous outflow obstruction in a lot of cases. Turns out it's not that easy to go back retrospectively and answer this. We haven't been looking for, positional venous impingements and things on our patients with exercise-associated compartment syndrome. So one of the things I'm trying to do right now is prospectively look at some of these patients who come referred to us with a diagnosis of exercise-induced compartment syndrome and see how many of them actually have fixed venous obstruction or some type of popliteal entrapment that is giving them this manifestation, this compartment syndrome. I don't know if that answers the question, but I think if that's what you're asking, you're on the right question. You're on the right path. We don't know.
The second part of this has to do with warfarin. Have you found that to be any significance with either compartment syndrome and/or DVT in the lower leg? Have you seen warfarin as creating problems for people that have compartment syndrome that have had past history of DVTs?
That's interesting. I guess I haven't seen warfarin creating problems for people, but as Patty points out, a lot of this is serendipity. I really haven't thought about it or looked for it. I haven't noticed it, but I can't tell you that there's not some type of association there. And I see a lot of these patients. This is why, I'm often in a fortunate position of coming to some of these conclusions or noticing some of these things, because I see a lot of them. But that's not an association that I've seen. Are you concerned that possibly warfarin causes more compartment syndrome or aggravates it?
I'm wondering if it might have an effect in some of the clotting mechanisms which result in increased extravasations of
Yeah.
fluids into an area which recreates compartment syndrome in people that
Yeah.
have had previous surgery to decompress,
Right.
as well as stroke. But 20 years ago I saw that, but now it's coming to fruition as far as perhaps being implicated in causing stroke. But I appreciate your input. Thank you.
Well, it's very interesting because, you know, any effect that warfarin might have to increase permeability and thus increase the amount of post-DVT compartment syndrome you see is probably offset by a little bit of what Patty showed us, that not everybody recanalizes at the same rate, and there'll be some people who get warfarin who may do better in the long run because they wind up with less obstruction. So the phenomenon you're describing may occur without it actually being something that becomes super evident because it gets offset by some people that do better. Great questions.
Just
Thank
a
you.
comment about
Thank you.
venous claudication. You may have a patient come to you with calf pain that's exercise-induced, and that's venous claudication in the calf. It gets a lot of things discussed, but at least in our experience, we're actually seeing that more commonly with an iliac vein lesion than we are with something in the leg. It may be obstruction that's post-phlebitic in the femoral vein, but iliac vein compression is classically described as causing thigh claudication, but you can see calf claudication with much less in the way of thigh symptoms that can raise the same kind of clinical scenario.
You know, and I would agree with that too. The point I made, wanted people to understand, is that when you get a funny symptom like calf claudication, think about, you know, deep venous disease, and definitely it can originate from something higher than a popliteal vein.
I think it's alarming to think that some people, young people, get fasciotomies
Yes.
for this because it's so invasive, and I don't think it actually solves the problem. Many cases they have iliac compression. Question,
here.
please.
There's a question for the panel and everybody. A clinical scenario of young patients with 50% stenosis in iliac vein. For instance, main common iliac vein would be 220, and you'd have a stenosis to 112, and yet they would have a superficial reflux as well in a leg, and class 4B symptoms, for instance. So you have a superficial reflux, 3-4 seconds, and yet you will have a 50% iliac compression in a vein. What comes first here? What do we need to address? And what is now current thinking of the, because my understanding was that the 50% compression in the vein can be significant, but what if it's a borderline? Is there any way to evaluate it, any way to say, okay, this patient needs to have a stent first, or do we need to go and ablate the vein first?
Did you measure the circumference of the legs? Is the leg bigger on the left than the right?
Correct, yes.
Yes, so that's another sign that the iliac compression is pretty significant. Dr. Sharifi, how would you deal with this problem?
This is a very good question. My recommendation is for people who are starting this, getting involved in the veins, is the framework and the understanding you have for the arterial disease does not necessarily apply to the venous disease in many aspects. One of them is the diameter stenosis. Actually, if you really have 50% stenosis, that's a high-grade stenosis in the venous system. There are reports that even 10 to 20% may be significant. So in your particular question, you address the obstruction first in the deep venous system, and then you go to the superficial venous system and address the reflux.
Oh, perfect, thank you.
Next question, please.
I'm hoping Dr. Dougherty can follow up on his comment that to look for iliocable thrombosis, you should start with an abdominal venous ultrasound. Many of us go right to CT or MR venography. If you had a negative abdominal ultrasound or positive, would you follow up with the MR or CT venography regardless of the findings?
Well, it depends on what we find. I think the ultrasound is a great way to initially evaluate these people and screen and sort out what's going on. The vast majority of the time, our technologists have the anatomy and the physiology pretty well worked out with the ultrasound. There are a few occasions when the symptoms are just so classic for there being an obstructive lesion that I'm just not able to write the patient off as having no pathology, and we will get cross-sectional imaging with an MRV. These days we use Ablavar for it to help in viewing the veins. And on a rare occasion, we find very significant lesions which our techs have missed. I can't say that we're not missing some, but I don't think we're missing many. The time I use the cross-sectional imaging with MR or CT really is to get more anatomic detail. Usually I've already figured out that we have a hemodynamically significant lesion which needs to be treated from the ultrasound, and I'm looking for more detail. Some criticize and say, well, you know, you don't need to spend the money on MRV or CTV if you've got ultrasound findings that show things, but it's surprising how often you find things you really didn't suspect as well that may, in some cases, influence what you're going to do or how you're going to approach it. But I really think ultrasound with the flow dynamics is one of the keys to sorting out whether these lesions are really significant. At rest, we figure out that we've got a high velocity or high velocity, peak venous velocity ratio. We look at the collateral flow, the retrograde flow, and internal iliac. And if we don't find what we think is going on, we may put the patient on treadmill, walk them for a little while, stimulate more venous flow out of the leg, and then show the lesion is more significant than we thought at rest. If we find it significant after exercise, then it's very real. Now the question is, how many things do we miss because we're not going straight to CT or MR, and I don't know the answer to that. I don't think we're missing a lot of important lesions, though.
I'd like to jump in here just with one comment and follow up. Dr. Zieler, I posed this question at a conference last week, actually, because I think in looking at our emergency room ultrasound reports, I'm seeing a lot of people coming in with a left leg or a right leg swelling, maybe even skin changes, and the report is no DVT. And they're only going from the inguinal ligament to hopefully mid-calf, looking at the tibials. However, the problem was that someone spoke up about it, said, well, you know, sure, you have a really great ultrasound tech. They work with you all the time, but out in the community, we have a lot of people who don't know how to do an abdominal ultrasound venous study. And I'm saying, my question for you now is, how much harder is it for a technologist to do an arterioabdominal study, which they do all the time on iliac arteries? How much harder is to learn how to look at the veins?
You know, that's a good question. I mean, my initial reaction is it should be about the same. I mean, if you can evaluate the aoroiliac arteries, you should be able to evaluate the IVC iliac venous system. You know, whether to add the IVC iliacs to a lower extremity duplex, because they're two different exams, is somewhat controversial, although I always tell my techs more testing is, in the ultrasound lab, more testing is usually better than less testing, and we have a very low threshold for adding that. And even when the common femoral vein waveforms are normal, I think there are still situations where you're going to want to go up and look at the IVC iliacs. I mean, if there's any clinical suspicion of anything going on more proximally, you know, we just do that. And I think that's important. And I think particularly with modern instrumentation, that there really is not much of an excuse for not trying to do that part of the exam.
Thank you. One question, please?
Yeah, I have a question.
Yes.
Yeah, a question. In the real world, we see a lot of people sent to us with leg swelling. And you got a spectrum of somebody whose femoral vein evaluation standing with leg compression, there's very little phasic flow, to somebody with a total occlusion that has the constant high velocity flow picture you see. My problem is, how do you pick out the people who have a little bit of May Thurners? And my gut reaction is there's a range from, you know, compress the leg, see if the femoral vein, at the groin, you know, a blip, and then very little respiratory movement, to as you get a little bit more of a iliac vein compression, maybe a little bit more pronounced respiratory variation. If you get a total occlusion, then you'll get the with a pattern that high velocity flow without the respiratory variation. Then you take people who are just 400 pounds and throw that into it. I mean, what I've done, if I see if I'm suspecting a May Thurner and I see a fairly pronounced respiratory variation or respiratory flow, then I'm thinking, well, maybe there's something going on there. But then you'll see that sometimes in people who are just big. And what I've done is, with them laying flat, compress the vein at the groin, measure flow in the, or actually compress above the ligament, measure the flow at the humeral vein, and let up, and see how much flow we get there, compare the two, and sometimes that helps out a little bit. But more of the flow, the idea of how do you do these little, I mean, what seems to work best for you? You're looking at somebody who's fat, a little bit of May Thurner, and a lot of May Thurner, to know what to do next.
Go ahead, Tom.
Fantastic question, and you've in part come to a bit of a practical solution. Yes, these 400-pound people are obstructed. They're all externally compressed by the mass around these veins. But what your comment reflects is something that Gene pointed out. He wasn't going to talk about physiological testing today. What you're talking about is the physiology of obstruction and the fact that we don't have good physiological tests to assess this the way we do for arterial disease. We're very good at running studies to figure out if a particular degree of stenosis or a particular lesion we see in an artery is actually producing a symptom. We're not very good at that with the veins. So we cobble, we put together different things, we improvise. We do what you did, for example, and we try to take an anatomic hemodynamic test like ultrasound, and by performing provocative maneuvers, by having the patient breathe and looking at the effects, we try to get our best guess about what the hemodynamic effect is. But the bottom line is that we really need to develop some better, easier, simple, more widespread technologies for assessing venous flow. That's the only way we're going to be able to answer your question in the long run. And these tools exist out there. They're just not widely available to the average practitioner. We haven't used them for years, and they haven't been well calibrated in all these different situations. But I share your frustration. There is no real good physiologic tests that we can hang our hat on for quantifying venous outflow obstruction.
We're eating into our break time, so could I ask you if you might ask your question of one of the panelists in person? Would that be okay? And because I want everybody to go take a break, see the vendors, come back, because when we get back, we're going to have live case presentation from Phoenix, Arizona. So thank you for being here this morning. Thank you.